LFT or liver function tests, also referred to as hepatic panel, are a group of
respiration includes ventilation.
Welcome to EazyMed, where complex medical concepts are made simple.
Hey everyone.
LFT or liver function tests, also referred to as hepatic panel, are a group of blood tests that measures the level of several substances that are enzymes and proteins excreted by your liver. Levels that are higher or lower than the normal can indicate liver problems. Several biochemical parameters are assessed in LFT. These are number 1, bilirubin, that is of two types, conjugated and unconjugated, alanine aminotransferase, abbreviated as ALT, aspartate aminotransferase, abbreviated as AST, alkaline phosphatase, abbreviated as ALP, gamma glutamyl transpeptidase as GGTP. Let's now see each of them one by one. Bilirubin. Bilirubin is a breakdown product of hemoglobin. When RBCs complete their lifespan, which is of 120 days, they are destroyed in the body and hemoglobin is released. The hemoglobin further breaks down into heme and globin component. The heme component is then converted into biliverdin, which further converted into bilirubin. This bilirubin is of unconjugated form, also referred to as indirect form, which is insoluble in water, so it binds with the albumin and then transported to the liver. In the liver, bilirubin is converted into conjugated form, which is water soluble and can be excreted easily through the urine or feces. So, if there is an increase in the level of bilirubin, it indicates something is wrong in your body. The main causes of bilirubin level in blood are number 1, hemolysis, that is the breakdown of RBCs, number 2, failure of conjugating system in liver, and number 3, obstruction in biliary system. Our next biochemical parameter or test is AST, aspartate aminotransferase. AST was previously called as SGOT, serum glutamate oxaloacetate transaminase. AST is high in heart, muscles, liver, skeletal muscles, but low in kidney, pancreas, and RBCs. Damaged tissue releases AST in blood, therefore, AST level in blood is directly related to the extent of cellular damage or injury. AST level in plasma is elevated for 8 hours after cellular injury and peak levels at 24 to 36 hours and returns to normal in 3 to 7 days. AST levels in blood is always higher in patients with number 1, chronic hepatocellular diseases, acute hepatitis, number 3, cirrhosis, and number 4, acute extrahepatic obstruction. Factors which interfere with the serum AST level includes number 1, pregnancy, in which there is a decrease in the AST levels. Number 2 is exercise, which increases the levels of AST. And number 3, drugs such as antihypertensives and oral contraceptives also interfere with the levels of AST. The third test we will talk about is alanine aminotransferase, ALT. ALT was previously called as SGPT, which stands for serum glutamate pyruvate transaminase. ALT is mainly found in liver. Lesser quantities are in heart, kidney, and skeletal muscles. Liver injury causes elevation of ALT levels in blood. ALT is more liver sensitive or specific indicator of liver diseases as compared to AST. Its level is directly related to the extent of cellular injury, and raised level of ALT can be seen in chronic alcoholism, hepatic cancer, and chronic cirrhosis. Alanine phosphatase, ALP. ALP is primarily found in liver, bones, and placenta. The test has low specificity for liver disorders because there are other conditions that can also increase the level of ALP. These are cholecystitis, in which there is an obstruction of intra or extrahepatic bile duct, pregnancy, Bone diseases, specifically osteoblastic cancers and Paget's diseases, and newborn growth can also cause elevation in ALP levels. So because of these uncertainties, another test is performed called as GGTP. GGTP, gamma glutamyl transpeptidase. This test is highly accurate in indicating cholecystitis. It is the most sensitive liver enzyme for detecting biliary obstruction, cholangitis or cholecystitis. GGTP level is very high in liver but low in kidney, heart, intestine, brain and prostate gland. Elevation of GGTP levels parallels that of ALP in liver diseases, but GGTP is not increased in bone disease. So, if ALP is increased but GGTP levels are normal, that indicate bone diseases.
Respiration includes ventilation, gas exchange between the air, blood, and tissues within the body, and the use of oxygen for metabolism. Inhalation allows oxygen to enter the body, pulling air into the nose and mouth, lungs, and into the air sacs, called alveoli, where gas exchange takes place. Alveoli move freely when air is inhaled and exhaled. Capillaries are small blood vessels that line the walls of the alveoli. During gas exchange, oxygen enters and carbon dioxide exits the bloodstream via the alveolo-capillary membrane. Once oxygen molecules move from the alveoli into the capillaries, they dissolve into the plasma and enter the red blood cell, or erythrocyte. Erythrocytes contain millions of soluble proteins called hemoglobin. Hemoglobin contains 4 subunits, each capable of binding one molecule of oxygen. Once one molecule of oxygen binds to one of the subunits, the other sites bind oxygen more readily. Dissolved and bound oxygen flows through the arterial bloodstream to capillaries within tissues. Upon arrival, carbon dioxide loading of the erythrocyte promotes oxygen unloading. Oxygen metabolism within cells produces carbon dioxide gas as a metabolic waste. Carbon dioxide exits the cells and tissues and is converted into bicarbonate within the erythrocytes. Converting carbon dioxide to bicarbonate releases hydrogen ions that decrease oxygen affinity for hemoglobin, freeing the oxygen to be delivered to tissue cells. After delivering oxygen to the tissues, the carbon dioxide-rich blood returns to the lungs through the venous circulation and then to the pulmonary artery. Inside each erythrocyte, the bicarbonate conversion is reversed, recreating carbon dioxide, which diffuses across the erythrocyte into the alveoli and lungs and is excreted out of the body.
Welcome to EazyMed, where complex medical concepts are made simple. In this video, we'll discuss about pneumonia, its causes, types, clinical manifestations, diagnosis, and treatment. Pneumonia is an acute infection of the lung parenchyma. Mechanisms that create a mechanical barrier to microorganisms include air filtration, epiglottis closure over the trachea, cough reflex, mucociliary escalator mechanism, and reflex bronchoconstriction. Pneumonia is more likely to occur when 1. The defense mechanism become incompetent or are overwhelmed by the virulence or quantity of infectious agents. 2. Air pollution, cigarette smoking, viral URIs, and normal changes that occur with aging. Organisms that cause pneumonia reach the lung by 3 methods. 1. Aspiration of normal flora from the nasopharynx or oropharynx. Many of the organisms that cause pneumonia are normal inhabitants of the pharynx in healthy adults. 2. Inhalation of microbes present in the air. Examples include mycoplasma pneumonia and fungal pneumonias. 3. Hematogenous spread from a primary infection elsewhere in the body. An example is Staphylococcus aureus. Now let's look onto the types of pneumonia. Community-acquired pneumonia, CAP, is an acute infection of the lung occurring in patients who have not been hospitalized or resided in a long-term care facility within 14 days of the onset of symptoms. Empiric antibiotic therapy should be started as soon as possible. Empiric therapy is the initiation of treatment before a definitive diagnosis. Hospital-associated pneumonia is pneumonia that occurs 48 hours or longer after hospital admission and was not incubating at the time of hospitalization. Ventilator-associated pneumonia, VAT, refers to pneumonia that occurs more than 48 hours after endotracheal intubation. Healthcare-associated pneumonia, HCAP, is a new onset pneumonia in a patient who 1. Was hospitalized in an acute care hospital for 2 days or longer within 90 days of the infection, 2. Resided in a long-term care facility, 3. Received IV antibiotic therapy, chemotherapy, or wound care within the past 30 days of the current infection, or attended a hospital or hemodialysis clinic. Aspiration pneumonia, occurring as either CAP or MCAP, results from the abnormal entry of material from the mouth or stomach into the trachea and lungs. Conditions that increase the risk of aspiration include decreased level of consciousness, difficulty swallowing, and nasogastric intubation with or without tube feeding. Opportunistic pneumonia. Individuals at risk for opportunistic pneumonia include those with altered immune responses. The most common presenting symptoms of pneumonia are cough, fever, shaking chills, dyspnea, tachypnea, and pleuritic chest pain. The cough may or may not be productive. Sputum may appear green, yellow, or even rust-colored. For diagnosis, on physical examination, rhonchi and crackles may be auscultated over the affected region. If consolidation is present, bronchial breath sounds, egophony, and increased fremitus may be noted. Chest X-ray often shows a typical pattern characteristic of infecting organism and is important in the diagnosis of pneumonia. ABGs may be obtained to assess hypoxemia. Pneumococcal vaccine is used to prevent S. pneumonia. Vaccination is recommended for individuals 65 years of age or older and younger patients who are at high risk. A one-time repeat vaccination in 5 years. In uncomplicated cases, the patient responds to drug therapy within 48 to 72 hours. Indications of improvement include decreased temperature, improved breathing, and reduced chest pain. Abnormal physical findings can last more than 7 days. A repeat chest X-ray is obtained in 6 to 8 weeks to assess for resolution. No definitive treatment exists for the majority of viral pneumonias. Care is generally supportive. Some important points. Patients with intubation and tubes are at risk for aspiration pneumonia. Elevate the head of the bed 30 to 45 degrees and monitor gastric residual volumes. Practice strict medical asepsis and adherence to infection control guidelines. Staff and visitors should wash their hands on entering and leaving the patient's room. Along with physical assessment, including pulse oximetry monitoring, prompt collection of specimens and initiation of antibiotics are critical. Oxygen therapy, hydration, nutritional support, breathing exercises, early ambulation, and therapeutic positioning are part of nursing management. Instruct the patient to drink plenty of liquids. Thank you for watching EazyMed. Keep learning, keep growing, and make medicine simple. Don't forget to like, share, and subscribe for more easy medical lessons.
Hey everyone, welcome back to EazyMed. In today's video, we'll be diving into some important MCQs on the respiratory system. A perfect way to test your knowledge and strengthen your concepts for exam. The nurse observes constant bubbling in the water seal chamber of a closed chest drainage system. What should the nurse conclude? 1. The system is functioning normally. 2. The client has a pneumothorax. 3. The system has an air leak. 4. The chest tube is obstructed. And the correct answer is 3. The system has an air leak. Rationales. Constant bubbling in the chamber indicates an air leak and requires immediate intervention. The client with a pneumothorax will have intermittent bubbling in the water seal chamber. Clients without a pneumothorax should have no evidence of bubbling in the chamber. If the tube is obstructed, the nurse should notice that the fluid has stopped fluctuating in the water seal chamber. A client has the following arterial blood gas, ABG values: pH 7.112, partial pressure of arterial carbon dioxide, 40 millimeters Högers, and bicarbonate, 15 milliliters per liter. These ABG values suggest which disorder? 1. Respiratory alkalosis. 2. Respiratory acidosis. 3. Metabolic alkalosis. 4. Metabolic acidosis. And the correct answer is 4. Metabolic acidosis rationales. This client's pH value is below normal, indicating acidosis. The HCO3 value also is below normal, reflecting an overwhelming accumulation of acids or excessive loss of base, which suggests metabolic acidosis. The PaCO2 value is normal, indicating absence of respiratory compensation. These ABG values eliminate the other options. A client, confused and short of breath, is brought to the emergency department by a family member. The medical history reveals chronic bronchitis and hypertension. To learn more about the client's current respiratory problem, the physician orders a chest X-ray and arterial blood gas (ABG) analysis. When reviewing the ABG report, the nurse sees many abbreviations. What does a lowercase a in an ABG value represent? 1. Acid-base balance. 2. Arterial blood. 3. Arterial oxygen saturation. 4. Alveoli. And the correct answer is 2. Arterial blood. Rationales. A lowercase a in an ABG value represents arterial blood. For instance, the abbreviation PaO2 refers to the partial pressure of oxygen in arterial blood. The pH value reflects the acid-base balance in arterial blood. SaO2 indicates arterial oxygen saturation. An uppercase A represents alveolar conditions. For example, PaO2 indicates the partial pressure of oxygen in the alveoli. A nurse is performing a respiratory assessment on a client with pneumonia. She asks the client to say 99 several times. Through her stethoscope, she hears the words clearly over his left lower lobe. What term should the nurse use to document this finding? 1. Bronchophony. 2. Tactile fremitus. 3. Crepitation. 4. Egophony. And the correct answer is 1. Bronchophony. Rationales. Bronchophony is an increased intensity and clarity of voice sounds heard over a bronchus surrounded by consolidated lung tissue. Over normal lung tissue, the words are unintelligible. However, over areas of tissue consolidation, such as with pneumonia, the words are clear because the tissue enhances the sounds. Tactile fremitus is the vibration felt when the client speaks while the nurse holds her hand against his chest. Crepitation is a crackling sound heard in certain diseases, such as pneumonia. Egophony is an abnormal change in tone heard when the client speaks normally as the nurse auscultates his chest. An adult client with cystic fibrosis is admitted to an acute care facility with an acute respiratory infection. Prescribed respiratory treatment includes chest physiotherapy. When should the nurse perform this procedure? 1. Immediately before a meal. 2. At least 2 hours after a meal. 3. When bronchospasms occur. 4. When secretions have mobilized. And the correct answer is 2. At least 2 hours after a meal. Rationales. The nurse should perform chest physiotherapy at least 2 hours after a meal to reduce the risk of vomiting and aspiration. Performing it immediately before a meal may tire the client and impair the ability to eat. Percussion and vibration, components of chest physiotherapy, may worsen bronchospasms. Therefore, the procedure is contraindicated in clients with bronchospasms. Secretions that have mobilized, especially when suction equipment isn't available, are a contraindication for postural drainage, another component of chest physiotherapy. The client with tuberculosis is to be discharged home with nursing follow-up. Which aspect of nursing care will have the highest priority? 1. Offering the client emotional support. 2. Teaching the client about the disease and its treatment. 3. Coordinating various agency services. 4. Assessing the client's environment for sanitation. And the correct answer is 2. Teaching the client about disease and its treatment. Rationale. Ensuring that the client is well educated about tuberculosis is the highest priority. Education of the client and family is essential to help the client understand the need for completing the prescribed drug therapy to cure the disease. Offering the client emotional support, coordinating various agency services, and assessing the environment may be part of the care for the client with tuberculosis. However, these interventions are of less importance than education about the disease process and its treatment. A recent immigrant from Vietnam is diagnosed with pulmonary tuberculosis, TB. Which intervention is most important for the nurse to implement with this client? 1. Client teaching about the cause of TB. 2. Reviewing the risk factors for TB. 3. Developing a list of people with whom the client has had contact. 4. Client teaching about the importance of TB. Correct answer is 3. Developing a list of people with whom the client has had contact. Rationales. To lessen the spread of TB, everyone who had contact with the client must undergo a chest X-ray and TB skin test. Testing will help determine if the client infected anyone else. The remaining options are important areas to address when educating high-risk populations about TB prior to its development. A nurse is caring for a client who has a tracheostomy and temperature of 103 degrees Fahrenheit. Which intervention will most likely lower the client's arterial blood oxygen saturation? 1. Endotracheal suctioning. 2. Encouragement of coughing. 3. Use of cooling blanket. 4. Incentive spirometry. And the correct answer is 1. Endotracheal suctioning. Rationales. Endotracheal suctioning removes secretions as well as gases from the airway and lowers the arterial oxygen saturation, SaO2 level. Coughing and incentive spirometry improve oxygenation and should raise or maintain oxygen saturation. Because of superficial vasoconstriction, using a cooling blanket can lower peripheral oxygen saturation readings, but SaO2 levels wouldn't be affected. A client with a history of asthma is admitted to the emergency department. The nurse notes that the client is dyspneic, with a respiratory rate of 35 breaths per min, nasal flaring, and use of accessory muscles. Auscultation of the lung fields reveals greatly diminished breath sounds. What should the nurse do first? 1. Initiate oxygen therapy as prescribed and reassess the client in 10 minutes. 2. Draw blood for an arterial blood gas. 3. Encourage the client to relax and breathe slowly through the mouth. 4. Administer bronchodilators as prescribed. And the correct answer is 4. Administer bronchodilators as prescribed. Rationale. In an acute asthma attack, diminished or absent breath sounds can be an ominous sign indicating lack of air movement in the lungs and impending respiratory failure. The client requires immediate intervention with inhaled bronchodilators, IV corticosteroids, and possibly IV theophylline. Administering oxygen and reassessing the client 10 minutes later would delay needed medical intervention, as would drawing blood for an arterial blood gas analysis. It would be futile to encourage the client to relax and breathe slowly without providing the necessary pharmacologic intervention. A client has a sucking stab wound to the chest. Which action should the nurse take first? 1. Draw blood for a hematocrit and hemoglobin level. 2. Apply a dressing over the wound and tape it on 3 sides. 3. Prepare a chest tube insertion tray. 4. Prepare to start an IV line. And the correct answer is 2. Apply a dressing over the wound and tape it on 3 sides. Rationales. The nurse should immediately apply a dressing over the stab wound and tape it on 3 sides to allow air to escape and to prevent tension pneumothorax, which is more life-threatening than an open chest wound. Only after covering and taping the wound should the nurse draw blood for laboratory tests, assist with chest tube insertion, and start an IV line. Thanks for watching. If you found this video helpful, don't forget to like, share, and subscribe to the channel for more such content.
LFT or liver function tests, also referred to as hepatic panel, are a group of blood tests that measures the level of several substances that are enzymes and proteins excreted by your liver. Levels that are higher or lower than the normal can indicate liver problems. Several biochemical parameters are assessed in LFT. These are number 1, bilirubin, that is of 2 types, conjugated and unconjugated, alanine aminotransferase, abbreviated as ALT, aspartate aminotransferase, abbreviated as AST, alkaline phosphatase, abbreviated as ALP, gamma glutamyl transpeptidase as GGTP. Let's now see each of them one by one. Bilirubin. Bilirubin is a breakdown product of hemoglobin. When RBCs complete their lifespan, which is of 120 days, they are destroyed in the body and hemoglobin is released. The hemoglobin further breaks down into heme and globin component. The heme component is then converted into biliverdin, which further converted into bilirubin. This bilirubin is of unconjugated form, also referred to as indirect form, which is insoluble in water, so it binds with the albumin and then transported to the liver. In the liver, bilirubin is converted into conjugated form, which is water soluble and can be excreted easily through the urine or feces. So, if there is an increase in the level of bilirubin, it indicates something is wrong in your body.